Thanks so much for joining for the Incredibles Fearless Family Story Pheo Para Genetics session of the Pheo Para Alliance Virtual Conference. My name is Melanie, and I'm a patient and caregiver. I'm here with Dr. Tobi Elsa and Jenae Osborne, who I'll properly introduce in a moment. But first, this program is brought to you by the Pheo Para Alliance, whose mission is to empower patients with pheochromocytoma or paraganglioma, their families, and medical professionals through advocacy, education, and a global community of support, while helping to advance research that accelerates treatments and cures. I'd like to extend a special thanks to Progenics and Advanced Accelerator Applications for making this conference possible. Before we get started, I'd also like to mention Pheo Para Awareness Week, which is actually this week. There are plenty of ways you can participate, and all the information can be found at pheopara.org. You can also share on social media and attend virtual events. Our agenda today will be that Dr. Tobi Elsa and Jenae will present for 25 minutes, and then I will briefly share my experience in ways in which I can encourage you to embrace your inner superhero with a focus on mind-body wellness. Then we'll begin answering questions from our attendees. Please remember that the information presented on this webinar is for educational purposes only and should not substitute the advice of your doctor and medical team because they have in-depth knowledge of your own medical history and current situation. The content of this program is not influenced by any of our sponsors or supporters. And now I'd like to introduce our experts for this session. Dr. Tobi Elsa from University of Michigan Health. Dr. Elsa's primary appointment is with the Division of Metabolism, Endocrinology, and Diabetes. He received his MD degree from the University of Hamburg, Germany. He pursued his clinical training at the University of Hamburg with a residency in internal medicine and the University of Michigan with residency internal medicine, fellowship, endocrinology. His main research interests are the genetics of endocrine tumors. Dr. Elsa's clinical practice focuses on the care for patients with benign and malignant endocrine tumors, particularly pheochromocytoma, adrenocortical tumors, and neuroendocrine tumors, as well as accompanying hormone excess syndromes, for example, Cushing syndrome and primary aldosteronism. Dr. Elsa has a particular interest in taking care of patients with hereditary syndromes that predispose to the development of endocrine tumors, for example, MEN type 1, MEN 2A, and MEN 2B, hereditary paraganglioma syndrome. He attends the multidisciplinary endocrine oncology clinic where patients with tumors receive diagnostic procedures and treatment. In addition, he is part of the Cancer Genetics Clinic, which evaluates patients for hereditary syndromes and also facilitates regular exams and surveillance for patients at risk for endocrine tumors. Thanks so much for being here with us, Dr. Elsa.
Thank you for having me.
And I'd also like to introduce Jenae Osborne from University of Michigan Health. Jenae is a 2008 graduate of the Indiana University Genetic Counseling Program. Prior to joining the genetic counseling team at UM in 2013, Jenae was a cancer genetic counselor in Knoxville for 5 years. Currently, Jenae is a senior genetic counselor working in the Cancer Genetics Clinic. She also provides genetic counseling for the Endocrine Oncology Clinic and serves as the point of contact for the UM-VHL Comprehensive Clinical Care Center through the VHL Alliance. She also is one of the co-directors of the Pheo Para Alliance Centers of Excellence at UM. Jenae is one of the primary supervisors for students rotating through the Cancer Genetics Clinic. Thank you so much for being here with us today, Jenae.
Thank you for having me.
All right, I will turn it over to the two of you for your presentation.
All right, I'm going to start sharing here. Let's make sure, can everybody see the screen now? Yes, good. All right, so yeah, thank you for the very kind introduction. I'm going to talk about the Pheo Para Patient Conference, the Incredibles, a Fearless family story, which we actually encounter over and over again because families are our patients, particularly in our genetics clinic, Pheo Para Genetics. I might be a little bit sidelining and being a little bit off topic because I would like to use this as a defining a roadmap for patients with Pheo Para, and particularly those with a genetic predisposition, and provide you the care perspective. And I think And this would be the overall recurring theme here, how we should actually work together as a team, because that's really what we are, particularly for our patients with a genetic predisposition. This is very often a lifetime relationship, right? Or at least for a very long time. I personally started seeing patients with any of these conditions a little bit more than 10 years ago. So there are several things which I would like to share with our patients, and I'm really excited to do this today. How we can actually make our relationship more fruitful on all fronts, meaning care as well as research and education. And part of that is, of course, taking part in patient organized meetings such as this one, which I always find really, really exciting. All right, so I'm gonna start this here. These are my disclosures, and usually this is the slide where you see it's like click, 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 and then there was disclosures, right? So I do think this is actually really important because I have a very personal view on disclosures. You see that I'm part of several, which actually pay me personally for this, scientific advisory boards. Although I would say that my primary impetus on taking part in those is actually to promote research in these fields with our pharmaceutical companies as our partners. And there had been some recent really exciting developments in the area for particularly Van Hippel-Lindau disease. And then there are those contracted studies where we do studies with our pharmaceutical partners, with our patients. I do think we always glance over this, and we never really mentioned this. But for example, our involvement in patient organizations is just another conflict of interest. I wouldn't even call them conflicts, right? So those are basically signs of our interest in this field, and that spans actually from patient care, pharmaceutical companies, research, professional societies, where I've been mainly involved in several of the guidelines that pertain to the field of patients I actually focus my care on. So I would like to start with an overview, a roadmap for care patients with rare diseases, expectations, the physician, genetic counselor, and researcher perspective, surveillance, and then I'll spend some time surveillance for individuals at risk for pheochromocytoma, paraganglioma, and other tumors. All right, so let's start with this roadmap a little bit. Diagnosis, now what? Whether you're diagnosed with a pheo or a para or a hereditary predisposition without a tumor, really become a fearless hero, right? So that actually goes back to the title. I think you are really the one who should lead the team. Find the right resources. Pheo Para Alliance is one of the really great examples. Find trustworthy web pages. If you need guidance for this, ask your physicians, genetic counselors you're working with, and you really over the first year or so, build your team, right? And it's a team building that goes on even beyond this initial time. And like I mentioned, this is very often the basis for, and I put this in quotes here, lifetime relations, because obviously we move around and it might not be lifetime, but it could be, right? And I find this particularly rewarding, taking care of families. And I remember my first patient with Van Hippel-Lindau disease. When I encountered this patient, it was really the first patient I saw when I was rotating through the cancer genetics clinic as a resident here. And she was a teenager at that time, and then she went on to undergrad and studied abroad. And then she went to medical school and she just started her residency. And it's just wonderful to see this play your part in guiding some of the health questions along the lines. All right. So there are several team components which are important. So everybody needs a general care, primary care physician, and this is a relationship which naturally should be built up on trust. You need expert care because those are rare conditions, rare tumors. And it's like a lot of primary care physicians will say, "Whoa, I can't take care of you. I don't know anything of this." Neither do they need to, because patients with rare conditions get common colds, they get the flu, they get COVID, right? But you need a primary care physician taking care of this. And then there are those expert care physicians, which the same principle of trust applied there, of course, but it's also driven by the expertise. Genetic counseling for family evaluation, family planning, and other subspecialty care for either therapy or surveillance. And really what you should look for is a tertiary quaternary care center, which also facilitates all the laboratory imaging and what else is needed for the care of patients with rare conditions. All right, so I put this in a little bit of a picture here. In the middle, there's the patient, the stakeholder, the leader of the team. You have the primary care physician, as I mentioned, and the expert core physician, which is the one who will guide the treatment for the rare condition and the surveillance in case of patients with a hereditary predisposition. So that's really the core care unit as I want to define it. But there's certainly way more to this, right? You have, subspecialty physicians for the diagnostic as well as treatment input, as well as treatment units, diagnostic physicians here again. And then you have other expert centers. I think that's always really important. It's like, we never function as one unit, even as a center of excellence in care for patients with a certain condition. Really other expert centers are really important for us. They are important in terms of research, patient care, national, international tumor boards, and just exchanging knowledge and expertise. And I certainly learned a lot for this. This is, by the way, and I mentioned that later also too, for a lot of our patients are seeking second or third opinions. And I absolutely encourage this because that's the way I learn a lot about this as well, right? And that's part of the really interesting aspect of this type of care. And then there are patient support groups. I mean, that's a moot point today because we all know what this is about, right? And family and friends. And family is particularly important when it comes to hereditary conditions. And Jenae will spend a couple of slides on that as well. Of course, insurance, which can be supportive, but can be our bane of our existence, right? So do we get certain scans covered? Do we not get it covered? And I actually have to say, once you start a higher level discussion with insurance, this actually works really well. So I encountered two roadblocks in my career. Number one was when insurance has said, any genetic testing is experimental, you're not going to do this. Well, what do we do in a genetic study if we can't do genetics testing, right? There's nothing much we can do. So we actually met with the leaders of our local main payers and discussed this issue with them. And they were very understanding, and pretty much not the next day, but over the course of the next year, everything resolved, and we all of a sudden could do our job again because they trusted us as a specialized clinic. And that is something that's important. Of course, you still have the peer-to-peers for a lot of things. And but even those can be scaled down once you call for a meeting with the stakeholders in insurances and peer-to-peer organizations. And it's actually, they are very interested because it also scales down their work, right? If they don't have to wait for a call, talk to you every week for your patients. And it's, from my perspective, something that's really not sustainable. If I have to do a half-hour peer-to-peer on all of my patients where I order something, it's just not sustainable. And I'd rather spend that time differently, for example, discussing the condition with my patients, right? All right. Okay, so the multidisciplinary team has different things they need to do in terms of the genetic predisposition. Expert core physicians should lead the surveillance that includes different subspecialties as mentioned there. And there should be also access to other subspecialties, which are really not at the core of care for this condition. And then therapy, same thing, again, different subspecialties and access to other core subspecialties, which don't occur necessarily regularly in this. But we can function as the core team to actually educate those providers, make them familiar with the condition, and lead to the best patient outcome. So what's the expert physician? So ideally, they should have experience, they should have cared for example, Pheo Para patients or related conditions before. That's always easier said than to find. I think there's also a lot of, and I, thinking about myself, I had this interest, and Michigan had a traditional interest in these conditions, but there was, when I came, there was nobody actually really doing this. So, sometimes it's also good to, like I put here, trust the young physician that might start a specialty clinic, because very often they're really smart people, they're very dedicated, and sometimes you might be better off with those guys than one of those old guys like I'm becoming right now. So have access to expertise and training, right? Seek learning opportunities. There should be a dedication for the expert physician, empathy, research interest, and they should be approachable, right? And they should have an integrative character. This is, I think, hugely important. So they should have access to an interdisciplinary network, and at least locally at our institution, this network is a lot of it is virtual, right? So for example, when I see a patient, we can do either of two things. And Probably even Hippo-Lindau disease is one of the better examples than the patients with an SDHX-related hereditary paraganglioma syndrome. You can meet with your urologist, endocrine surgeon, a neurosurgeon, and you can scale this up to 10, 12 appointments, including imaging a year. But that's also not sustainable for the patient, right? So what I like to do is to actually keep it all together and say, okay, you'll meet with me if you'd like to. If you like to meet all these other people, we can certainly make this happen. And I will have a short way of communication with my colleagues. If I find something where I say it's like, I'm not really sure, I need to get a second opinion here, I can actually send them a message through our electronic medical records, get a fairly fast answer, and then we can figure out whether we need to have a true referral or whether that time is for physician and patients spent in a different way. So ideally, I always say is like, for our patients with a hereditary predisposition syndrome, I always like to see them 1 or 2 days a year, and the other 364 days they can spend in a different way than thinking of their inherited condition. And of course, we all appreciate second and maybe even third opinions. With a fourth, it might become a little bit different. No, I'm just kidding here, but I think this is a great learning experience for us, and I always really appreciate that. And I do that for my patients a lot. That I ask other people, so it's like, hey, what do you think? What should we do here? How do you approach this? And it's always unique things that come up, right? For example, transplant in patients with hereditary conditions. Do we do that? I mean, the transplant folks are really afraid of this, but once you tell them, it's like, listen, I don't think that the cancer chance of tumor development or cancer development is greater on the immunosuppression for our folks. You can change this, and we have several patients who underwent transplant by now. I think that's another important example for where you actually intersect with other areas. All right, so we got 2 multidisciplinary clinics, and I'll just make this very short. We have the cancer genetics clinic, which is 1 full day. We actually really have a preclinical discussion about all of our patients, and then we have the patient visitor, usually with the physician, as well as with a genetic counselor, at least in the beginning. Later on, there is an as-needed genetic counselor, like for family planning, further family diagnosis, and other things. So we always have an availability of each other. And then we should come up with a common care plan that ideally should be communicated definitely to the patient, but also shared with a primary care physician. All right, so this is our cancer genetics clinic, which I just show here. That you see that there's certainly not just me involved, but a whole lot of other people who probably do much work than more work than I do. And then we have our endocrine oncology clinic, where it's more about patients who are actually diagnosed with a certain tumor. There's a possibility for a visit or a remote second opinion on occasion. Patient, stakeholder, and expert core physician are there, but we have the tumor board where everybody comes together again, discusses the patient with imaging, other findings, and again comes up with a care plan that will just be communicated accordingly. This is the team there. Again, it's a bigger team than myself. We never work just on our own. I'm just the main link between those 2 clinics here. So what are the advantages of a multidisciplinary clinic? You get an immediate available subspecialty expertise by a lot of providers. You can actually integrate different opinions. And that also means that we should bring cases there where we even believe that we're really sure this is what we should do. And sometimes you're surprised that things actually change, and that we are also ourselves convinced that some other route might be the better way to go. It's important provider and patient learning, right, from gaining experience, interdisciplinary exchange. It's a short way of communication. It just makes it so much easier than writing letters and waiting for answers. And it's a compact visit, which is time saving and actually prevents also the loss of information. Then there's, of course, the larger perspective, which I already mentioned, the family and friends, which are incredibly important. And I said already, in cancer genetics clinics, we really take care of families and not of single patients. Insurances, I already commented on that, patient organizations, and of course, expert panels, right? So all these things are important in the care for our patients. A couple of additional comments here is like, know your team, identify a primary care physician. I already mentioned that, and identify a main specialty physician. That's what I would really like to get from our patients, gather all information that can be brought to the visit for a review, and facilitate communication between your physicians, as well as identifying best ways. Some people like email, phone calls, and that is all, I think, important to set the right expectations there. This is something that's dear to my heart because I'm part of several research networks that are actually focusing on these conditions as well, particularly Van Hippel-Lindau disease, as well as the SDHX-related hereditary paraganglioma syndrome. Be familiar with the institution and healthcare facility policies regarding research, right? So, and this is something that comes up over and over again. And I give you some examples here. It's like, for example, when you see somebody at the NIH, that's a research facility. Everything that's done there is research. Patients walk through the door and are a research patient, right? Which is much, much different in a lot of other institutions. So where there's the opt-in and opt-out variants, right? So for example, the University of Michigan is opt-in. So we actually approach every single patient of us to consent them to a larger registry, right? And I think this also applies to patient care, right? So is, are all the scans you get as part of a research protocol, is that for clinical care? No, it's primarily for research, but it might be for, also used for clinical care occasionally. Although we need to be really, really careful with this, and I put this in here because some of the research we do is actually not going by the same dedicated and controlled routes as for example, the clinical care, right? So they're not the same standard operating procedures in place, right? So labs are often not CLIA certified, which ensures that from the blood draw to the analysis, it's the same patient, right? So just be aware what is research, what is care, and where is, of course, there's always this intersection of those, right? So that's why research results are often not validated for the same clinical care. Of course, clinical therapy studies are extremely important, and it's always for us also a great excitement to take part in this. And in most facilities, participation in research is optional. And I always make this point, it shouldn't influence how we take care of patients, because that's a very personal and ethical condition, whether a decision whether you would like to take part in this or not. And it will never influence the patient care. Well, it's like, of course, we're happy if we can see patients on a research basis as well. But if our patients prefer to be in the usual care route, that's just as exciting for us as including them in research studies. So there will be never any bad blood arising from that. All right, so I'll spend a couple of minutes here on the surveillance for gene carriers at risk for pheochromocytoma and paragangliomas. Those are the main conditions we encounter here: multiple endocrine neoplasia type 2, Van Hippel-Lindau disease, and then the succinate dehydrogenase variant-related hereditary paraganglioma syndrome. And there are a couple of other rare ones, which I will not comment on. If there are any questions about this, we can certainly address that as well. This is just an overview how these distribute in our clinic. So this is about 400 individuals here. Probably the biggest part here are VHL, but all taken together, the patients with SDHX are really the biggest group, right? Now, what do we do for patients? Really for the MEN2 patients, lab draws is the mainstay of identifying pheochromocytoma as well as other manifestation. No imaging is necessary. Van Hippel-Lindau disease, labs, but imaging and other surveillance is necessary as well. And this is one of my my favorite things to really underscore, because what I realize in the field of, or with a lot of new Van Hippel-Lindau disease patients, is that they have been followed by some physician in uro-oncology, urology, or neurosurgery, or an endocrinologist for one little aspect of the complete picture. And you realize they never had, like, they have been treated for renal cell cancers, but never anybody looked at the brain and the spine for hemangioblastomas there, or for a pheochromocytoma in the adrenal gland. And I think that's really largely important. For SDHX, we do actually labs and imaging. Currently, we have kind of two options here. what we still prefer mostly is every year whole body MRI, every other year whole body MRI and annual metanephrines, just because not all tumors are actually hormone producing. And then there's also the suggestion from a recent excellent expert consensus statement to use PET-based imaging. There are advantages and disadvantages for both, and I'll get to this in a second. The question is, what do we try to detect, right? Pheochromocytoma, but also for the SDHX, renal cell cancer, and the rare GIST that remain rare in patients with this, but it's important, right? All of these are very slow growing tumors. I think that's the other thing. It's like nobody ever wakes up with a large tumor and it's too late, right? And that's why we say it's like every 2 years is actually absolutely feasible in most cases. So, and you want to diagnose before issues arise, which is mainly the metastatic disease, which we would like to prevent. So catching tumors early is really the core point there. And of course, they're compromised due to nerves, for example, nerves due to local growth, particularly with the head and neck paragangliomas, and then health issues due to the catecholamines, so the adrenaline and noradrenaline, which can lead to heart disease, stroke in the long run. So the option one, we like this because it detects at least Pheo and particularly the renal cell cancer. Maybe just, we're not really sure about that. There's no radiation. They're not very convenient. And frankly, whole body MRI has a low availability. There's not a lot of centers that do this, right? What about FDG PET? Well, it's probably really, really good in SDHX carriers for Pheo Para, maybe renal cell cancer, maybe just, but there's less data for this. And the dotatate scan is really good for Pheos and Para, but likely the renal cell cancer and just might escape that imaging. Larger lesions you will also see because there's a CT scan, so a true cross-sectional imaging in parallel to that. But, they contain radiation over the course of a lifetime that might accumulate to a unwanted cumulative dose. So that's why I still, whenever possible, go with a non-radiation containing variants here. They're more convenient, they are shorter, and there's a widespread availability, particularly for the FDG PET, which is commonly available. But, what should I do? There are all these options out there. Well, first of all, guidelines and expert opinions are used for guidance. They are not rules set in stone. And we always discuss this, as it was mentioned in the preamble of today's talk here. Is like we always discuss this on an individual basis. I think we can be guided by this, but we very often make different decisions which diverge from the usual guidelines, right? And that's based on, patient means, physicians' interpretation of other results, and so on. Make an informed decision with your providers. That's really the core of what we do, right? And I always find this funny because I think this is how every decision with a patient should be made or by a patient should be made, because they are really the leaders of the team, right? And probably the two options I provided you before are fairly equivalent in detection rates. So it's not that one is definitely wrong and the other one is definitely right. In the long run, one might turn out to be better than the other ones. How often do you need surveillance? Annual blood draws are recommended, and physician visits for going over other symptoms and a physical exam. At most, every 2 years, imaging for patients with SDH variants. Again, they're extremely slow growing neoplasm. That's why we feel good with this. Weigh benefits, early detection versus risk, right? And one of the things I always like to mention there is that, when we start doing these here, think of, for example, patients with SDHB. There's an estimate that only 1 in 3 patients with a hereditary predisposition will ever develop a tumor, right? So they will go through a lifelong surveillance without finding a tumor. This is actually exactly what we want, right? Even the ones where we find one, we hopefully only find one once or twice, right? That's really what we want. So there's also on the patient side sometimes the screening fatigue is, right? What are you doing? You never find anything. Oh, that's what we want, right? So no gastroenterologist will close their practice because they didn't see a colon cancer that day, right? And that's recommended for everybody in terms of colon cancer, right? Screening. So that's very important to discuss and set these expectations for that, right, as well. And I think actually comparing that the general risks of other tumors in the population is important. So particularly when it comes to the range of SDHA, and we can always have a discussion about this, where it's, probably the lifetime chance is like 5%, maybe less. Look at the clearly cancers that are in a much more common. It's like breast cancer in women about 12%, colon cancer in the overall population 5%, right? Having a perspective is always important here, and that's where I would like to conclude at this moment. Like I said, I did a focus on, or I actually gave you the broad perspective of care for patients with hereditary syndromes and pheochromocytoma, paraganglioma. I'm always happy to talk about specific genetics questions. That's what we do every day. But I just wanted to share some of those things here, which I think are really important for us all to make the care experience as good and as excellent as possible. And it's a family thing. And that's, of course, the time where I will pass the mic to the virtual mic to Jenae.
Thank you. And so, like Dr. Elsa said, he presented on after a diagnosis, what do we need to do for you personally? But I want to take a moment to say, what do we think about when it comes to family care? So on the next slide, whenever there has been a hereditary condition identified, whether it's VHL or whether it's a hereditary paraganglioma and pheochromocytoma, it is not just the person who has that tumor or condition themselves, but it's also their relatives. And it's important to share this information with your relatives. Not only does it give them a chance to stop and consider, do I need to have testing? Do I need to think about what should I do, even though my relative has this condition? Does it affect me? So the best way to do that is to let your relatives know that you have this information, that you have genetic test results, that you have some information that they have received from their specialists, their team. And it's important to know that not every relative that you go to talk to about this information will be interested right at that moment. Some will soak it up like a sponge and want to jump on testing as soon as they can. Others, it might take a little bit of time for them to ponder and come to acceptance that, maybe I should look into this a little bit more for myself. So every family dynamic is a little bit different, and your family more than anyone else. And so it's important for you to realize how your family may respond to information that there might be something genetic or something that's running through the family. So is going to the next slide, looking at what information to share with your relatives. It's really important that if you've had some genetic testing done that has identified one of these conditions, that you get a copy of your genetic test results. Oftentimes when you go to a genetic center and you meet with a genetic counselor, we get that right into your hand as soon as possible. If you've had your testing coordinated by someone else, sometimes you may need to request it. But it's important to have that because it gives us a roadmap. It knows what actual genetic change was identified. And so we can test your other relatives for that known genetic change. Our institution here at the University of Michigan, we create a family letter for everyone who has been diagnosed with a condition. And this is a easy way to share this information with your family, saying, dear relative, I've been diagnosed with this genetic condition, and this is my genetic mutation. It's important for you to talk to your doctor and to see if you should have testing for this. So if you have something like that, share it with your relatives. If you have a consult note or some note from your physician of saying, what should we do next? Share that with your relatives. If your doctor took a family tree or a family pedigree, as we refer to it in genetics, if you have a copy of that, that will make it easier for your brother or your sister to have that family history to share with their doctor who's trying to coordinate their genetic testing. And finally, if you were shared, if someone shared with you the screening and management recommendations, sometimes sharing that information with your relative may be helpful for them to understand what it means to have the genetic testing. So if I have this genetic condition, I'm going to be going for some blood work. oh, I'm going to maybe have some imaging done. So they kind of know what those next steps are. It might help them as they're deciding on whether or not they want to do genetic testing themselves. So I just touched on things a little bit. When it comes to the question and answers, if there's more specific questions or concerns on how do I share this information with my family, it's a very individual thing. Every family responds in different ways. And so we all have different techniques and some different recommendations that we can share with you. And I'd be happy to talk more on that. At the University of Michigan, this is some of our team. And so just to share that with you, we have a lot of different physicians that work together in the care for those with Pheos and Paras. So with that, I am going to pass the mic on to Melanie. I think she is going to talk with us a little bit more before the question and answers.
Thanks so much, Tobi and Jenae, for sharing that wonderful information with all of us. I'd like to remind everyone that we will have a short Q&A session afterwards. So if you'd like to type any questions that you have in the chat, we'll get to as many of them as we can after. So I'd like to tell you a little bit about my own journey and hopefully provide some ways that you can empower yourself as it relates to this session. Our experts have already mentioned a lot of the same things that I had prepared to share. So I do apologize for any repetition. So as you can see on my screen, my name is Melanie. I am a patient and a caregiver. I am actually a von Hippel-Lindau patient. I was diagnosed 8 years ago when I was 34 and my son was 4 years old at the time. So we have been dealing with this for a while. I got the mutation from my father, and one of my sisters and her 2 daughters also carried the same mutation. So it is very much, as we stated, a family affair. And we are, thankfully able to support each other. So I kind of, for prepping this, I kind of asked myself the question, is getting a genetic diagnosis a blessing or a curse? And for me, after 18 years of fighting to get a diagnosis, it was actually really vindicating. And although I certainly would prefer not to have VHL, I've come around to finding some reasons that it's kind of a blessing. So I'll try my best to give you some tips for managing life with a genetic disease from a patient perspective, and also the reasons that I do feel blessed, keeping in mind that nobody's journey is the same. But I do hope that at least some of what I say in the next few minutes might resonate with you. I'll start with the medical side of things, reminding you all that I am actually in Canada. So our medical system does differ slightly from that of the United States. But for me, having a genetic diagnosis means that I now have access to regular scans without having to wait a really long time for scheduling. It means that I don't have to fight to be seen by a doctor or a specialist, and that I do have a long list of specialists that work together to make up my medical care team, which I would have difficulty accessing without that genetic diagnosis. And that being said, it's really so vitally important to keep on top of your scans and appointments. I know that a lot of patients skirt their appointments time to time or often because of the anxiety that these can cause. And as a fellow patient and caregiver, I can honestly say that I'm very familiar with the anxiety and stress that can be caused by these appointments. It's so common that we've coined a term, scanxiety, so you're not alone. So how do we deal with these anxieties and stresses? For me, I try and constantly remind myself that these scans and appointments are an integral part of managing my health, that even if there's unwanted news that comes from them, they're actually changing my outcomes for the better because they're allowing me to access needed treatment sooner and more efficiently. And then I brace myself and try to breathe through the worry. At the end of the day, the scans themselves aren't responsible for what's happening in my body, and not knowing doesn't help me in any way. If you find it difficult to stay on top of scheduling and going to appointments, because believe me, I know it's a lot, you can ask for help from your family for scheduling and reminders, and your medical team may also be willing to help with this. I suggest that you build yourself a medical team that is understanding and supportive, and learn to work in partnership with them. Don't be afraid to ask for second and third opinions. Don't be afraid to switch doctors if you can, to find someone who's on the same page as you. Not all doctors and patients are a good fit, and that's okay. Do your own research as much as you can, bits and pieces at a time. You don't have to do it all at once. But knowledge is power. Finding other patients with similar experience and knowledge is great. But remember also that for the most part, they aren't doctors or researchers and are sharing their own journey. Try to look for trusted medical sources when doing research, as well as those invaluable patient sources. Search medical journals and sites and articles. Look for ones that are easy to understand, or try to find someone that can help you understand the jargon. You do get better at it as you go along. For me, knowing about my illness and treatments helps me to feel in control, and it helps me to self-advocate with my medical team. And a quick note on advocating, it can feel hard to do this, but you must self-advocate with your team. Where I am right now, we have a campaign called What Matters to You. Your medical team needs to know what's important to you as a person as you face life with this genetic diagnosis. Take some time to think about for yourself. What are your hard lines? Sharing this with your team and family will assist in medical decisions about how to proceed with treatment. When my grandpa was very ill, his doctor had recommended a surgery which was not without its risks. My grandpa thought about it and asked, well, will I still be able to eat ice cream and watch hockey? Assured that he would, he went ahead with the surgery and enjoyed many more years of good quality life doing things that he enjoyed. In later days, when he was too ill to express his own wishes, will he still be able to eat ice cream and watch hockey? Became a guiding light for our family and his medical team as we made decisions regarding his care. Find a team who sees you as a whole person, not just your illness and its treatment. I also would recommend to you that you try to recognize your needs versus your wants. I always ask for them both with my medical team, but if it's a need, I insist. If it's a want, I still will ask, but I also recognize that sometimes doctors have their own needs and there are places where we can compromise. This will help build a good relationship of trust with your team. From a medical standpoint, remember that this is your journey and your fight, and only you can decide how you want to walk the path. From a more personal level, I can say that having a diagnosis has vastly increased the amount of support I've come across. It's given me a whole other community of people that I can connect with, not just for Pheo Para, but for VHL in general. I met my best friend through the VHL community, and we've been able to support each other through surgeries. Don't be afraid to reach out and lean on the community. They have many wonderful resources that they can provide you with, both for me and my physicians, but also about current guidelines, treatments, and also ongoing research, which can give us hope for the future. Keep your body as fit as you can. I know that's tough for a lot of us, but exercise does help with anxiety and mood control, and keeping your body in fighting shape always helps with recovery. I'm not saying you have to go to the gym, but find a way to keep your body moving that you enjoy. Take walks with your family after dinner, go cycling, hike, swim, or by all means, go to the gym if that's your jam. Just make it a bold goal to keep your body moving. Try to take time for yourself when you need it, which can be hard in our busy lives, but find time in whatever way you can to unplug and enjoy all the things that you can still do with your body, however you can make that work for you. Laugh as much as you can, find music that makes you smile, surround yourself with people who lift you up, watch funny movies. Laughter helps us heal and makes life worth living. After my most recent pancreatic surgery, my husband purchased a shirt for me that says, "Not cool, pancreas, not cool." It's still one of my favorites. Find a purpose for yourself. Maybe you're going through this so you can help others going through the same thing. Maybe your purpose is your children if you have them. Maybe your purpose is to research and support. Whatever it is, find something that fulfills you. Love the ones around you fiercely and let yourself be loved in return. Form strong bonds with your family. Don't hide your illness. Let them see your strength in adversity. On bad days, remind yourself, my track record for getting through bad days, 100% so far. That's pretty darn good. I invite you to consider this question. What growth has your illness provided you with? More compassion, more empathy, more knowledge of your own strength, a conviction to live each day to the fullest. I'll leave you with two of my favorite quotes, which I refer to often. The first is, however bad life may seem, there's always something you can do and succeed at. Where there is life, there is hope. And the second, rise and rise again, and again, like the phoenix from the ashes, until the lambs have become lions. Thanks very much, everyone. We'll move on to our question and answer session. You'll have to give me a second. I'm on a tablet, so I've got to
That was really wonderful, Melanie. Thank you so much. You mentioned something in the side note, which I would like to comment on, because I think that's also important, particularly for patient organizations. So as you mentioned in my introduction, I'm from Germany, where we have yet a different healthcare system. You experience more nationalized in Canada. And I practice in a country where there is a great lobbying against something like national or socialized healthcare systems. And I'm so glad that you're saying that you feel well taken care of once you have the diagnosis. I think this is something that is really, really important. And as I already mentioned, sometimes the struggle with insurances for us is really, really difficult. And I see that a lot of my colleagues and other systems do not have this. So they do not have this patient and physician barrier. I think that's just something which is important to keep in mind when we think about healthcare systems.
Thanks so much. So I will get started going through these questions. I'm wondering if either of you could talk about having received variants of unknown significance in genetic testing.
Jenae, would you like to say something? I can also, just whatever you like.
Why don't you go ahead?
Well, so in general, what happens is we take a family history, we take a personal history, we send blood off for genetic testing if we feel that's indicated and if the patient wishes so, and we get a result back, right? So which means like, yeah, they might find something unique to this patient, right? Which they don't find in another 130,000 people that are out there in databases where they say, this is unique to you. And then they go back to other criteria of the lab and say, it's like, well, we'll look in a database where patients with the same condition are described, and we don't find it there either. So if they find it there and multiple times, then it will be classified as what's called a pathogenic, so a disease-causing, a risk-increasing variant, right? If they find it too often in the 130,000 people, they'll call it benign, so not disease causing, not risk increasing. Everything else is in this variance of uncertain significance range, right? Now those will be reclassified hopefully at some point, going either or the other direction. Frankly, most of them go into the don't matter direction. But some of them go into the pathogenic direction, so meaning they increase the risk. I do think it's incredibly important that if you send off genetic testing and you get this result back from the lab only comments what the lab knows, right? So if I see somebody, for example, with a head and neck paraganglioma and an abdominal paraganglioma, and the dad had the same thing, and I see a variant in SDHD, which is, or multiple family members have the same thing, and I see a variant in SDHD, I remain very suspicious. The lab may call it VUS, variant of uncertain significance, but I remain suspicious. So that happens on occasion, not very often, but it happens. And the way to go through this is first in the family to see whether it actually tracks with the family, in the family, with whether the ones that actually also have a paraganglioma or a pheochromocytoma do have the same variants, and the other ones that don't have it do not. And that can be very helpful also in reclassifying these variants for other people. Now, having this said, I think it's really, really important to consider what does the patient actually have, and what does the family have in terms of making a clinical decision, whether we truly treat it as a VUS, variant of uncertain significance, or whether we're a little bit more suspicious that it might be associated with disease. And we can work against what the lab says. That's something we do.
Another helpful tip is there are some national databases such as ClinVar. So if one lab is calling it a variant, it might be helpful to look to see if other labs are also classifying it the same way, as that might help us to help weed that out a little bit.
Yeah, not always, but everybody agrees on this. That's another important thing, right? So, and not everybody has access to the same information, and you have the unique information about your patient and your family. So I think that's what we need to base this on, how we clinically act up on those variants.
Thanks. I'm just going to move on to the next question so we can get a couple more answered before we run out of time. Do you have any tips that patients can provide their healthcare providers or their insurance companies on the need for genetic testing for de novo cases or first in family?
So I think that if you have a question, sometimes some physicians is not the first and foremost in their mind to go to genetics. So if you have a question saying, "Hey, should I look at genetics?" Bring it up with your doctors, and say, I was at a conference and they said almost everyone with a pheo or a paraganglioma should have a genetics evaluation. Maybe that's all they need to help prompt that discussion to refer. If you're having a little bit more challenges on someone not understanding where to even go, there is the National Society of Genetic Counselors, nsgc.org, where you can search for a genetic counselor. You can maybe even call or email one to say, is this something that I should do and how do I go about it? That's another valuable resource in trying to make this connection with a genetics provider.
Yeah, and you see that I let Jenae answer this question because they are much more experienced, the genetic counselors, with this, right? But in general, I think referring a patient for genetic counseling and then genetic testing to a genetic counselor is really the way it should go. And that is also usually you end up with medical professionals where the wheels are well greased in terms of getting insurance approval and things like that, or alternatives. Like most testing companies nowadays say it's like for $250 we'll test you regardless, for whatever you like. You can even order that on the internet. Not that I would recommend this, because I think the counseling part is hugely important for this, and particularly the discussion of the results. But just to make sure that there are options.
Thank you both. And would you, just to be clear, for someone who's newly diagnosed with a pheo or para, would you recommend that they insist upon or seek out genetic testing?
Yes, absolutely. So so pheo para overall, it's 1 in 3 people who will have a what we call pathogenic germline variant, so have a genetic predisposition to develop this tumor. So that's why we invariably test or recommend testing to all of our patients with a pheochromocytoma or paraganglioma. Of course, the range of suspicion varies, right? Particularly with a non-adrenal paraganglioma and a high family history and a head and neck paraganglioma, you will end up with likely a 90% chance or close to 90% chance that you will find something. While if it's an elderly patient with an adrenal pheochromocytoma only without a family history, chances drop slightly below 10%, but it's still 1 in 10, which is, or 1 in 12, something like that, where we still would definitely recommend considering genetic testing. Yes, everybody with a pheo para should have genetic testing.
Agree.
Thanks. I've got maybe time for one more that just came in. Are pathologists able to diagnose these tumors? Our family has the SDHC variant, and my sister, who has a tumor under her tongue area after 2 pregnancies and had ovarian tumor, now has chest wall tumor. None have been diagnosed as paraganglioma. She doesn't want to have genetic testing.
So I think this is a very complex question, right? But so let me tell first, if there is a pheochromocytoma or paraganglioma, pathologists have the means to narrow down whether it is associated with the with a potential underlying genetic variant. They do that by immunostains and so on. So that's, yes, they can actually narrow it down. It's not perfect, and it's not perfect for all the SDHs, but that's something that can be done. But the other important question is, and that goes back to what Jenae said. I mean, actually 2 things before I get to that is actually, we very often don't necessarily know all the tumors yet that are associated with this, where there's a slight increase, not knowing what the tumor under the tongue or the ovarian tumor are in specifics. They might occur in patients with this underlying genetic phenotype, with a genotype. It might be a little bit more common, but not that we really know of it now, because of course the pheochromocytomas and paragangliomas are the most common. That's why we know about this, and this is how it was discovered. But others will be over time probably added to this, not with a striking risk, but maybe with a slight increased risk. Other thing, of course, important is like with an ovarian tumor, if that's, for example, ovarian cancer, there is other genetic testing that would be definitely recommended for this patient. And the other thing, which Jenae can probably speak more to, is like the sister does not want to have genetic testing, right? So this is something to explore and discuss, which can happen on the family basis or with a genetic counselor. And maybe Jenae can say something about this.
Yeah, everybody's approach to genetic testing is a very personal one. Some people are very information seeking. They want to have this. They want to know, is there a genetic cause for what me and my family are going through? And others are more resistant. So if you have a relative who is not open to testing right now, from this, it sounds like she is going through a lot right now with this diagnosis and what they're finding. And right now may not be this snapshot in time that we should push the genetic testing. Those of us who are in genetics are saying this would be great, but maybe for her personally, she needs a little bit more time to think about things, gather things. We need to support one another, no matter if we decide to or against testing. They're still part of the family and be there for them. I think sometimes just in time, the various individuals will say, okay, all right, I've got this behind me. Now let's look at the genetics, or maybe this is SDHC. Maybe we need to think something even broader, because we are seeing more than just what we normally see with SDHC going on. So there's a lot of different things, and we just need to be aware that not everybody is as open to genetic testing as you may be.
All right, thank you so much. We need to wrap up now. I would like to thank both of you so very much for your time and your dedication to the patient community and for being here with us today. Special thanks again as well to Progenics and our other sponsors for making this conference possible. And a reminder that this and all of the sessions will be available for viewing on this platform. Please do tune into the rest of the conference sessions in coming days. And as always, we encourage you to participate in Awareness Week. Go to pheopara.org for the toolkit and to learn about ways that you can raise awareness. Thanks so much to everyone who attended today. And we wish you all a Pheo Para Fearless Day.
Thank you so much, Melanie, and everybody. It's wonderful.
Take care, everyone.